continue the kind of the discussion on our trainee perspective and I'll ask our two moderators to lead us through that discussion. So Emily Gallagher, who is the Research and Residency Director at Mount Sinai, and Barbara Kazmierczak, who is the MD PhD Director at Yale, will continue our discussion.
So hello, everyone. I'm going to just thank everybody for what was really an amazing discussion, and hopefully we can continue this, but now bring more of your voices into the conversation. So Emily, do you want to get us going with this, with the slides?
Sure. So let me see. You can see the slides?
Yep.
Okay.
Yes.
All right. So this is a technical glitch waiting to happen. But anyway, we decided we would use Poll Everywhere. So this, the goals basically of this session are going to be to hopefully identify some areas of potential disconnect in the perceptions between the faculty and the trainees, to examine some of the differences between our institutions, discuss areas where we can improve, and consider ways in which we can better advise or prepare trainees for careers as physician scientists. So the way we'll do this is that we're going to have Poll Everywhere set up. So this will just take a second. But here is how to join. So you can do this on your phone or via on the internet or via text. And I'll just give you a second to take down the details to join. So with each question, we're going to go through, I'm going to present the questions, which hopefully will work. And then Barbara is going to open it up to the trainees for perspectives, and then we'll open it up to the faculty to kind of follow up with the discussion. Okay, so I'm going to get going. Okay, so the first question that we wanted to pose was whether graduates enter residency training programs with realistic expectations of the career scientist path. And so we'll ask you to vote on whether you agree, neutral, disagree, strongly disagree. Okay, so I can see results are coming in. So I'm gonna go back to so you can still keep answering, it should keep changing.
Emily, are you able to save this data? Do you know? I'm happy to, actually we're recording it, so we'll be able to get it.
Oh. You can probably screenshot it otherwise. Your answers are anonymous, I should say that. So we're not recording who's answering what. Okay, so everybody wants to wrap up their votes. I'm gonna lock in the results. Okay, Barbara, do you want to open it up?
Yeah, so to the trainees who are just on this discussion, it seems as if nobody strongly agrees that you are going to be entering into this training pathway with the appropriate sort of and realistic expectations. And I think especially to Babak and AK, I mean, when you started training and now that you've actually been in the process, I'm curious what it is that you think was perhaps unrealistic or what you were unprepared for.
Yeah, I actually think I strongly disagree with this. I think the couple of things that I think were big surprises to me. One, I still feel this way. I feel like residency was a nuclear bomb in terms of sort of reorienting myself to what medicine and what being a physician entails. That was such an immersive experience, and it was, I think, really required a complete commitment for the 2 years that I was in it. And then on top of it, fellowship, I think, was also a complete reversal, and not a reversal, but it was, I was not able, I don't think there's any discussions I could have had as an MD PhD student to really prepare me for what it meant to be somebody's oncologist. And at Cornell, we have a fellows clinic. So we have our own patients, and of course we have our own attendings who supervise us and help us, but the patients are ours. And so when they call or they have issues from their chemo or immunotherapy, whatever, we're the ones who manage it. And, you know, I had talked to a lot of people when I was leaving medical school and applying for PSTP tracks about what it meant to be a oncologist who had a lab, a physician scientist. And everyone sort of, all of the faculty that I talked to made this point that, you know, you're their patient, and patient care always takes away from research time. And it may have just been me, but I don't think I truly understood that until I have experienced it. And when a patient calls or there's a patient issue, that is the priority, and it doesn't matter. There's no science that is a priority for that. So that has been a big learning experience for me, and a lot of people have been very helpful for how you manage that and how do you protect yourself. So when you're in the lab, you can protect that and focus on the lab. I think the other thing about it too is we get a little bit of this in training, and I think was very lucky to have some amazing mentorship. But I just think the hiring process, the politics of big academic medical centers, which we're all aspiring to be at, it's tough to prepare yourself for that and for what you need on your CV to become a competitive candidate. So, you know, I think those are the two really big surprising things that I've encountered and am grappling with.
Look, those were really great points. I was thinking, AK, actually, before I ask you, I think our next question might be a good one to put to the audience first, and then AK, I'll invite you to comment on that. So for all of those who are listening, PSTP, MD, PhD program directors, research and residency, I ask you, can you please type in what you think are realistic expectations that your trainees hold as they enter into residency training? This is a word cloud function, so you should be able to just answer a phrase, a word. So I think we can maybe stop the poll in just a few seconds here. Yeah. So clearly we see an emphasis on training, a realistic expectation of training, both clinical and research. I think there's a hope for balance. And then I think there's a lot of other important things here about what our trainees realistically expect from this period. Now, I'd like we can come back, I think, to this slide because it's locked. The next word cloud, I think we should probably also, before we open up for discussion.
Okay, it's locked.
I like the person who wrote sleep. But this also, I think we see some obvious things that we've brought up: publication funding, salaries. Perfection is really interesting. Bobak, I wonder if this gets a little bit to what you were saying and to what some of the other speakers have brought up, this idea that you're supposed to be the best doctor and the best scientist. And I think our realization that this is really challenging, if not impossible to do. So I'm looking in the chat here, and Don, I think you ask a really good question. You want to unmute yourself and bring up this mentoring idea?
Well, it's not so much in the unrealistic aspect of it, but in the realistic aspect of, I think my own bias is that probably the most important thing is mentorship. And part of this is that senior faculty and people who are physician scientists need to be as enthusiastic and as encouraging as possible. Young people look up to us, and when we complain and gripe and whatnot, that doesn't help. So maybe we need to focus on mentoring a little bit. I'm not sure.
AK, would you like to sort of comment on these?
I think I like the first word that popped up, which was like equal. And I think it covers like a lot of what I felt was unrealistic, from that as it would say, you will have equal, salary, equal workload. You will always have more work, and that's fine. But I don't know if one really appreciates that. And the same equal part was being like, as Bobak branched into, like being the doctor for your patients. And for me, that's something in this phase of my career where I just started faculty. I think it just dawns on me that the way, which is ideal, I won't have a clinic for the first 3 years, which I need to establish my lab and build everything up. That's what everybody tells you, and that is perfect. But I'm doing hematology, oncology, BMT, so I will be on service only for 6 weeks. These patients are my patient, but they're actually, in most of the times, they are the patients of one of my colleagues, right? So I don't have my own patient. That really hurts me, because I love being the doctor whom the patients call, and I really miss that. But I know I shouldn't miss it because it really enables me to do what I'm doing at the moment. And I think if everything goes as well as one would want to, right? I get more grants, I get less coverage time. My service time will even go down. I might never have a clinic. I think this is something one might not know, when one goes into it. At least it wasn't as clear to me.
Are there any other comments from the trainees in response to this, or to the directors?
Yeah, I agree with that, what AK was saying. I mean, just honestly hearing you talk about, being on service on the BMT service a couple of weeks a year, I think that makes me uncomfortable for a couple of reasons. One is I would be nervous that I would not be competent by the end of the 3 years when I have my own patients. But then, like you're saying, you don't have the the joy, the fun of having your own patients. And I think one of the things that cuts both ways in this training pathway or in this career is that the clinic and the science can really drain you of energy, but they can also do the opposite, which is you can get a lot of energy from patients and the satisfaction of being in clinic when the science isn't going well, and sort of vice versa. So I think that tension between the two is something you always have to balance, and it's complicated because at least as a trainee, you're still developing competencies, and you're always, questioning your own confidence in it. So, and I just add one more quick thing that I think is not talked about a lot in sort of the PSTP and MD PhD pathway, and that's that, if especially in the oncology world, if you want to be a good clinician, you have to learn how to interpret trials and be able to use judgment when a new drug comes out, with a phase 3 study, and you have to be able to smartly break that down and to interpret it and to tell your patients. And that's a skill set that people spend a whole degree getting, but it's really critical to being a good doctor and feeling confident about it. And I think that's a sort of another area that I certainly feel have pressure, in addition to learning the newest, CRISPR technologies, in order to provide good care.
So to the PSTP directors who are in the audience, research and residency directors, are there any comments you want to make in terms of this potentially highlighting, I think especially the trainees' responses, things we need to address in terms of preparing our trainees? Cameron, you're saying a lot of self-expectation of being a perfect doctor. I think that's a really interesting point. Do you want to unmute yourself and expand on that?
Yeah, I'm listening to this and thinking about how, especially Bobek's comments about, your CRISPR technology, you'll find a collaborator who you'll lean on and who may always know more than you for what you're doing. I don't know, I feel very much the same way as a clinician, that I'm a very good clinician, but I understand that I have people who are much, much more experienced than me, and I go to them, and that I have always found that acceptable. And so I'm wondering if we're training people to feel like if you're a doctor, you have to be able to know it all. So I don't know. I just don't know if we're setting expectations unreasonably.
If I can pipe in, because I was writing that in the chat just as Cameron was talking, and I 100% agree. And I see this issue all the time at MGH, where there's this expectation that to be a good physician, you must be a complete generalist. You must be a great hospitalist, this master clinician. And I think it's okay to set expectations such that you can be an amazing physician in a narrow area of subspecialization, so that you can balance being an amazing scientist, which is always by definition a narrow area of specialization, with a narrow area of specialization as a clinician. And I think we need to celebrate that, actually, so that our trainees don't feel like they're giving up on being a doctor just because they've really focused on something.
Great points. Personally, I'm feeling that right now as the ID consultant on call. Bobek, there's really this expectation that you're the expert, and yet in this broad field, I'm so grateful that I can go to my colleagues and say, I actually don't know this as well as you, because you're a doctor full time. So I'm glad that Carrie brought up the fact that we have other things to offer, and I wonder if our culture celebrates that enough, about the role that physician scientists play in bringing science to medicine, and if they're not necessarily the clinical expert in everything.
Yeah, I don't know how much of that, honestly, in defense of all the wonderful mentors I have, is from mentorship or more just self, expectations that, you put on yourself. So, but those are, appreciate those points too. I think that could be helpful if we maybe make it a little bit more normal to expect to be the best lung cancer doctor, but not nephrologist in addition to that.
Yeah, I'll say I think that those kind of expectations maybe start during dual degree programs too, in that at least I sort of expect to collect all of the currency that I can in both avenues, right? I want to get as many publications. I want to do as well as I can. I want to honor all my different things so that, that you can be competitive. And I think that partially is because you're sort of in with your colleagues who have that sort of heightened level of competition, and maybe thinking about really, there's these additional tracks like PSTPs where we're really looking for people who have focused in an area and have trained. That might change people's perspectives of like that these are sort of these heightened area of competition for people. So I think at the training level, at least from my perspective, that there is that definite perception that these are even more competitive programs rather than trying to identify people who would be good fits for this sort of interdisciplinary work. So
it's a really great point. Thank you, Jose. Emily, do you
Yeah.
think we should move on?
Yeah, definitely. So I think Jose gave us a good segue into the next question, which is here. So are you personally, in whatever your role is in training, concerned about the clinical competency of the graduates entering the clinician scientist residency training? Okay, so we have a little bit of a split here. So we're going to move on to the next question to as a comparative results. If we can give you like 5 more seconds and then I'm going to lock in the answer. Okay, so we can just kind of look at this for a second and then we're going to do the second question, which is related. So do you think your residency and/or fellowship directors are concerned about the clinical competency of the graduates entering clinician scientist postgraduate training? Okay, so I'll give it a few more seconds. It looks like it's more or less everybody's finished. Oh, sorry. So this one is basically locked in. So I think this is an interesting discussion, and we have another kind of step, which is the kind of the word cloud that I guess we can move into before we open it up for discussion. Which is, what do you think are the main concerns from the clinical perspective? And you can, again, type in words here and they'll start to appear. Okay, so this one is locked. So do you want to open it up, Barbara?
Yeah, there was a lot of really interesting stuff coming up here. So I think the reason we had 2 questions that we polled you on was to get a sense of how you felt about the trainees with whom you work as MD, PhD, or PSTP program directors. And then the second one was to sort of capture whether you thought that your feelings about the trainees' preparedness clinically was shared by your colleagues at your institutions. And clearly the answer was no. So I wonder if I could ask the trainees, do you feel like there's a concern on your part when you're applying for residency, or maybe in Jose's case, that you will be worried about, you know, how clinically competent you are when you compare yourself to students who are coming in, you know, with a straight MD or DO into the residency?
Yeah, I think the bit of advice was actually someone at MGH. I had the opportunity to speak one of the residency directors at MGH, and what she specifically told me was that the residency directors need to approve the you know, your board application. So like the advanced or integrated pathways that you might be involved in are like there is some sort of level of application that the board approves, and that this is something that you apply for during your first couple of months during your residency. And so that gave me a lot of confidence. And I don't think specifically that it's usually addressed during these webinars about like what actually happens. Like we talk about the PSTP and applying, but then and that there are those different tracks that you can go to, but like specifically saying, you know, there's going to be an application, you're working with a team of individuals to actually get that approved. I think I was surprised to see the fellowship questions there, that there was less confidence. But for me, I think specifically knowing how that works gave me a lot more confidence about, you know, the clinical competencies that you would get during those residencies. So I don't think a lot of trainees know like the intimate details of how that works when you're applying to programs. And so maybe it needs to be better advertised about like what the actual process is, and knowing that you don't really need to worry about that aspect when you're applying. You're going to do that once you're actually at a specific institution.
May I just say very, perhaps it's like a minority comment to the clinical competency. I personally noted it from during my interviews, you know, being an international medical graduate, and I think there was a very high hesitation. I know that some programs don't take international medical graduates, as good as your scores can be. And I think when I was talking to directors, and I'm curious what people would say to that, that seemed to be something where they said, well, you know, we don't know how good your medical school training was, or, you know, anything else that would go in. So I felt that there was specifically for the small group of international graduates a very high worry that the competence may not be as good, especially if you do a shortened training within a PSDP.
Yeah, I didn't run into a lot of concerns, and as I had mentioned before, I was nervous about only doing 2 years, but once I was in it, by the end of the 2 years, I felt like I knew what I needed to know from an internal medicine perspective. I think the clinical knowledge of fellowship is a little bit different, and I'm obviously still being trained in that. But I think it's just different because it really feels like a different world too, in terms of oncology. But yeah, I thought this, now that I'm on this side of it, I sort of look back and I think that all the worries and concerns I had about the 2 years were really overblown. And you know, what pretty much all the people that I went to ask about it, they said the same thing, like, you're going to be fine after 2 years. And I really do feel that I don't think you needed more than that. And I think at least in my PSTP, you know, my colleagues were wonderful, and I think there weren't any issues and around the hospital, or feeling confident and competent by the time we were done with the 2 years.
So I just want to ask, of the people who maybe type this into the word cloud, if you feel comfortable, there's a little bit of interest coming up, I think, in terms of the main concern. We can all understand perhaps the competence and confidence and experience, you know, concerns, but how serious is it, do you think, that that physician scientist trainees are perceived as being disinterested in patient care?
So I'll offer up because I was one of the people that wrote in interest because that has been something that that I've heard back in response to this kind of general feeling that physician scientist trainees are really interested in the science, but they're not interested in the clinical care. And to be completely honest, if you actually ask them for specific examples, the examples fail. This is a general kind of I don't know, it's a general feeling that I don't think is actually represented in fact. And I would say with all of these issues, it is not represented in fact. And I've started tracking outcomes since I've been in charge of the PSP program at MGH, and we see absolutely no significant increase in any of these issues with our PSP applicants. And yet still with some of our clinical faculty, we hit our heads against the wall because there's still this kind of rumor that a PSP is just staring at a cell paper and not actually like thinking and not interested in regurgitating the New England Journal of Medicine paper for that trial. And I think that what we do again and again is really try and break these assumptions that PSPs don't care about clinical care. But it's a hard nut to crack.
Harry, thanks for saying that. I think that if we hope to get anything out of this session, it's perhaps to sort of break some of these misperceptions about this pathway and the people who enter upon it. Emily, I think our next questions kind of get to that. So maybe we can kind of quickly run through them because I'm also cognizant of time running short.
Sure. So this one is basically kind of related. So do you think the postgraduate research pathway training for clinician scientists is too long, about right, or too short?
Just to make sure we're clear, that's the combined clinical and research postgraduate training, right, that you're referring to?
Yeah, yes.
Thanks.
Okay, so you can lock this in. So most people are slightly more than half thinking it's too long, and a minority thinking it's too short. Do we want to briefly let people comment on this before we move on?
Anybody want to chime in with if it's too long, where can we cut it?
So I could chime in here. My impression is actually that it's none of these answers. And I don't think it's really a matter of length. I think it's more about what we're doing during the training. You know, how are we incorporating, you know, sort of clinical and research training as we're talking about? Are we waiting too long? You know, we talked earlier about how difficult it is to get K awards. Imagine if, you know, we could, you know, if our trainees didn't have sort of this issue of completely tying, you know, the K to faculty position or how many first author papers you've generated during your training. I think that if we could bring the K award into this earlier, you know, our trainees would do a lot better. Same thing goes for the clinical instructor position. So it's really, again, not as much about length as it is restructuring the training.
Another point, and it's come up in this forum before, is the length of the MSTP training now, or actually even before they get into PSTP. You know, fairly common now for most MSTP applicants to have done several years of post-grad training prior to even starting their MSTP. And I really sort of wonder, is that necessary? Sort of compound the problem.
Thank you for those. Maybe we'll just move on, Emily.
Okay, so then, so this is related to applicants who are applying to the research versus categorical postgraduate pathways. So do you think that graduates who match into the research versus categorical residency tracks perceive that there is differences in the subsequent opportunities that they have to pursue careers as faculty clinician scientists? Okay, and then we're going to go with the next question. So do you as the faculty member think that there is actually a real difference in the subsequent opportunities that the trainees can pursue after if they go into the research pathway versus the categorical pathway?
Okay. I don't know if we have time to unpack what I think is a really interesting, again, perhaps discrepancy between maybe what trainees expect of their entry into a competitive, but then mentored, sponsored, full of training pathway as being sort of a key part of their success. And I think what many of us believe is a system that hopefully allows people who are, as we call them, maybe late bloomers or ones who are not entirely clear at the time of application to residency about whether they want to be categorical or PSTP, that in the end, the track does not determine the success of the physician scientist. Does anyone want to make a quick comment here or reflect on this?
Yeah, I think it comes back to what Dr. Abel said about perseverance, is the people who are willing to persevere really are the ones who succeed regardless of which pathway they go through.
Perhaps it also speaks to the fact that many of the opportunities that trainees have all along this continuum are always available if they want to and feel, able to take advantage of them, right?
Well, and I think it also reflects the fact that probably many of us are on this career path not having gone through formal PSTP programs. We took advantage of some of these opportunities that have now been more formalized. And so I completely agree. There's many different ways to get there. I think, the advantage of the PSTP is perhaps offering more guidance and mentoring earlier on in the process. But I think if someone's committed to this, there's many opportunities to enter into this pipeline.
Okay, right.
I think I'll just make a comment. So I think that the key is protected research time. And so I think that a huge benefit of the PSTP is that you're guaranteed one extra year, and that year can be critical. So I think institutional, if you do a categorical residency, but you're interested in research, I think as Miles said about persistence, if you're really motivated and persistent, I think you will be able to convince the institution to provide you with that protection. But I think having that a solid block of protected research time is important.
Great, thanks. Emily?
Okay, so so we can move through the remaining ones relatively quickly, and I'd probably open up some thoughts for discussion for the afternoon. So regarding tracking, does your institution or program track the information such as demographic information or long-term outcomes of your research pathway graduates?
just to clarify, are you asking about MSTP or PSTP?
PSTP. So after the residency, like the research pathway, the residency and fellowship. Okay, so this is probably something that can be opened up a little bit later on in the breakout session regarding tracking and best practices for tracking outcomes. Okay, and then do you know what percent of your research, again, PSTP graduates completing the fellowship obtain a career development award in your institution? Okay, so I can lock this one. And then the third question that's sort of related is, what percent of your research pathway graduates, again, after completing the fellowship, remain at your institution for their first faculty position? Okay, so do we want to open it up for a few comments?
This is Chris. I'll just say that when we surveyed medicine PSTPs, I think it was 3 years ago, a vast majority of them were only about 5 years old in a very organized fashion. So it might be a little bit early to have solid outcomes data. And I think Patrick and several others mentioned that in the chat.
I had a question, maybe others have the answer or not, but I'm just curious about how this compares to folks who might pursue those board approved routes for shortening or integrating their research at a categorical program that might not have a PSTP. And maybe that's another place where you could help with re-entering by like helping those folks who might be interested in pursuing those paths, but not have the particular resources at their institution to do so. I'm not sure if that's a possibility, but just curious.
And I think that's a really important point for discussion in this group. There's a struggle, I think, to try to come up with a sort of laid out training pathway that I think as an MSTP director, I'm very familiar with. And I think in some sense, the PSTPs are trying to become also more codified, if you will. But in both of our realms, the way of trying to bring people on board who've come through a less than sort of not this traditional path, I think is still an area of struggle and also of tremendous missed opportunity. So I think your point's really important, Jose, and I hope the PSTP folks on the call can consider that later on. So I just want to throw this out there because it came up in the chat, and I think it's an important point, and maybe it can be discussed during one of the networking breaks. But Lisa Vandevus from the University of Washington actually had a question about the trainees' perspectives, about whether it was more important that, you know, the mentors and the directors of programs remain optimistic and encouraging, or realistic and normalizing about the rigors of a physician scientist career path. And I think that's something that would be really important for us to know. Maybe we need to be both. But if I think we're running out of time, Chris, I'm going to defer to you whether we should bring that up as a water cooler conversation in the next few minutes and rejoin.
Thanks, Barbara. I think we'll try to keep it on track.